I'd like to introduce another Virginian. Down the road also at VCU, Dr. Sandra Welch is also a member of the Department of Pharmacology and Toxicity at VCU. Let us welcome Dr. Welch.
Thank you very much. I'm very happy to be here today, and what I'm going to be talking about are the interactions of the cannabinoids and the opioids in producing an analgesic effect. And Dr. Martin started me off on a good track by discussing his studies on dependence. I'll allude to some dependence studies, but mostly I'll be talking about the effects of these two drugs in combination and the potential for drug combination therapies based upon that. So first of all, here we have our cannabis sativa, and of course we know, as we've heard from many people today, that there are many, many compounds that may or may not be active. These compounds have not been studied, but there are certainly numerous compounds that are present in cannabis. And the only one that I'm going to talk about today is delta-9-THC. Now you may ask, why have we only done the studies with delta-9-THC, and beyond that, you might ask, why haven't we used the plant material? Well, first of all, we were trying to get these studies to be as clinically relevant as possible, and so Marinol, being a Schedule III drug, is a drug that is available, and we are heavily pushing it as for a potential indication as an adjunct for analgesia. And so, excuse me, so the studies that we have done have been done with oral delta-9-THC, and the human studies that we have been done with Marinol. Now, we've talked today about all of these different things that delta-9 might be involved in, and that marijuana might be involved in, but what I'm going to talk about are the studies with pain, and I'm going to be talking, as I said, about Marinol. In fact, I'm going to be talking about pure delta-9-THC because, again, like Dr. Martin said, have only marginally been involved with human studies, but all of our work has been done in rats and mice. So when you compare these two, there are the pros and cons of using Marinol and using the plant material, and clearly you can see all of the differences, and I'm not going to get into those various differences. Clearly the plant material is cheaper. Clearly the Marinol is great for a pharmacologist because it's one compound, and pharmacologists are devoid of the ability to understand that things might be combined and actually produce effects. And in fact, drug companies very frequently don't like the idea of having two drugs in combination being administered because it's very difficult to get those kinds of things approved. So we have stuck with the one drug. However, we have done studies with CBD and CBN as well. And if anybody has comments on that or wants to ask me any questions, I can answer those later. Okay, there are two types of cannabinoid receptors. I'm going to run through this really fast. The CB1 receptor, which is present in the brain and mediates the psychoactive effects of the cannabinoids, and has this selective antagonist, which is now called rimonabant. And you may have seen this on television. It has gotten a lot of press lately because it not only causes weight reduction, it causes the craving for nicotine to decrease, so you can decrease your smoking theoretically and decrease your weight at the same time. And so there's been quite a bit of press on this, as well as for various other types of craving. The CB2 receptor is very interesting, and that was alluded to by Dr. Meshulam, in that the immune responses of the cannabinoids are very prominent. And I'll be talking at the very end about the effects of delta-9 by itself as an analgesic in arthritic animals. It's far more potent in our hands in arthritic animals than it is in non-arthritic animals, or in mice, excuse me. It is far more potent in the arthritis model and in paw pressure models where you have pressure effects on the paw than it is in various other models of pain. And that may be due to the fact that there is an inflammatory mediator involved in this. This is the CB1 receptor. And there are the various classical cannabinoids that you've been hearing about today. We have done our studies, and we've been publishing on this combination since 1992, when our first study came out. And what we did show was that delta-9 enhances the effects of various of the opioids, and delta-8 enhances various of the effects of the opioids. That cannabinol and cannabidiol do not enhance the effects of the opioids. That doesn't mean that they're not useful, and certainly at this meeting we've seen that these are useful for other purposes. But for the purpose of enhancing an analgesic effect, they don't do that. As we all know, delta-9 is the active, psychoactive constituent of the marijuana plant. And having said that, what I want to point out is the whole point of this study is to decrease the amount of an opioid that is used down so low that you don't develop tolerance to the opioid, and to decrease the amount of THC that is used down so low that you don't have the psychoactive effects. You put the two together and you get a very large analgesic high efficacy effect. That's the goal of the study. This is appealing because you decrease these psychoactive effects that are present when you give high doses of THC, but you also decrease all of those side effects, which are pretty nasty, from taking high-dose opioids. And in the case of cancer patients, etc., this is a very critical issue. It's life-threatening to develop constipation from taking really high doses of the opioids. So why not use a low dose of the opioid in combination with Marinol and get an equal analgesic effect to a high-dose opioid alone? This has appeal to practitioners, docs that are being hit by the DEA now for the use of high doses of opioids to handle pain. This came up in a conference in New York that I was at, many of them complaining that their records are being checked, etc., because they're using too high a doses of the opioids. Pain clearly is a killer. Pain will debilitate, pain will increase stress responses, and the outcome of patients in pain is not as good as people who have their pain controlled. And so if you're going to be attacked for using a high enough opioid to block the effects of pain, then perhaps the way to go, since the chemists haven't come up with a perfect opioid yet, is to use this drug combination. And so that is what we are attempting to show you today. The reason that these two drugs work so well in combination is that there has long been known, and I believe it was 1858 or whatever that Ethan mentioned today, that it was first hypothesized, and Raphael Shulam sent me some articles a long time ago showing me that way back in folk medicine it was known that opioids and cannabinoids would synergize. So this wasn't just a new idea that just came about because of my thought process. But as we were going through this, obviously, people didn't know why the two might synergize. Well, what we have shown in our lab, and I'm going to just show you on this slide here, is that when a cannabinoid is administered, what that cannabinoid does is tickle the endogenous, naturally occurring opioid system that we all have. And for those of you that aren't familiar with that, you've all heard of runner's high and beta-endorphin being a natural opioid. There are many others, and the one that cannabinoids like to tickle and release is one called dynorphin, which is a natural occurring endogenous opioid. So here we have delta-9 THC binds to its receptor, and through a process that we don't understand yet, it actually releases a product of the endogenous opioid peptide, which acts in the body very similarly to that of morphine. And so if you have an endogenous opioid being released and you give somebody morphine, it only makes sense that you've got two factions of the opioid system being stimulated at the same time. Why wouldn't you have synergy? And in fact, as I said, this is nothing new. Here's from Matheson talking about the opioid combination with delta-9 THC, and here's Birch, another physician back in the 19th century, showing the same thing. So, and again, all of these things that I'm presenting today are in your handout. All my slides are exactly in your handout for you to look at. But, so this isn't anything new, but what we did show in our laboratory is clearly that morphine and delta-9 THC synergize, and the likelihood is that synergy involves the interaction of morphine at mu, delta, and kappa receptors, and which morphine produces side effects such as sedation, constipation, and depression, respiratory depression, and tolerance and dependence. But that if you put the two drugs together in combination, you can obviate the side effects, and you can obviate the tolerance and the physical dependence. In fact, the data that I will show you, and I'm just going to go through this first data really quickly because of time, we have shown that when you give THC, you increase two natural opioid peptides. One is leucine and kephalin, and the other is dynorphin. The interesting part of dynorphin is dynorphin can go either direction in producing pain or blocking pain. Dynorphin is really high in arthritics, and THC brings it back to normal levels. In a non-arthritic animal, dynorphin is low, and THC raises it, producing an analgesic effect. I'll come back to that, but it goes along with THC being a very powerful homeostatic regulator, especially of the endogenous opioid system. So this is just one study. We do rats. Jason Schechter is here in the back today, has worked with me for a good while now, and we have looked at the release of endogenous opioids by actually going in at the time the animal is administered the opioid, at the time the animal is producing a behavior, at the time the animal is analgesic, and measuring the amount of the endogenous opioid being released at that time point, so that you can't say, oh, it's something that's down the line. It's something that happens right then at the same time. And this is just one of the simple figures showing that when THC is administered, dynorphin A goes up. And I think all of you can see that. It clearly goes up very high. And leucine and kephalin goes up as well. These are endogenous opioids. So again, our question, and based upon the Institute of Medicine, which said that THC might be a useful adjunct to other analgesics, we said, well, good idea. Okay, we're going to see if, first of all, there is a synergy. And starting in 1992, before the Institute of Medicine actually, we did show there was a synergy. We showed that, and you can read through this, I won't read it to you, that it does involve the release of endogenous opioid peptides. And so this diagram just indicates the fact that when THC releases these endogenous opioid peptides, those endogenous opioids go and they bind to their opioid receptor. Then you put morphine on board to bind to the mu receptor, and you've got the full system engaged. And so you've got a synergistic interaction. And so the first hypothesis I just want to show you is can we do this enhancement by an oral route? Our first studies were all done in a spinal route. Can we do it with an oral route? And again, that goes back to the fact that we wanted to use Marinol since it is a Schedule III drug and it's available. And so we first used acute pain models, and we used mice, and this is something called a tail flick machine. It's just a thermal stimulus. It's a little bit like touching a hot stove where you pull your finger away. It's very innocuous. And we have measured the dose-response curves. Pharmacologists love dose-response curves. And so we measured the dose-response curve of morphine by itself and morphine in the combination of a low, inactive, totally analgesically inactive by itself dose of delta-9 THC. And here what you see is that the dose of morphine is on the x-axis, and the y-axis, the higher this goes, the higher the analgesia. So morphine by itself is a full analgesic, produces 100% analgesia. But you've got to use a dose of almost 80 milligram per kilogram to 100 milligram per kilogram orally in mice to get that full 100% effect. However, you can reduce that down by more than fourfold by injecting the delta-9 THC along with the morphine. And in fact, what we did was we showed this. Here's another diagram showing the shift. It's the shift over to the left, meaning that morphine became more potent. Look at the shift with codeine. This is maybe hard to see, but we showed that this was a synergistic, meaning 1 + 1 = 6 interaction. It's not purely additive. It is a synergistic interaction between the drugs using something called an isobolographic analysis, which is what is necessary to prove synergy in a pharmacological way. We showed the same thing with codeine. But more importantly, we went through a whole list, a whole grocery list of opioids, and have added to this list by now. And we found that here this potency ratio, PR, indicates how much more potent morphine becomes when you have an inactive dose of THC with it, meaning that you can get away with 2.2-fold less morphine. Here you can get away with 25.8-fold less codeine. And so it enhanced codeine 25-fold. Methadone, which we thought was very interesting for methadone clinics and for withdrawal in methadone clinics when there's always a problem with not enough methadone being on board. Oxymorphone, hydromorphone, LAM, meperidine, Demerol, heroin, and I'll talk about fentanyl in just a minute. So there were a wide variety of opioids that were enhanced. So we knew for sure we could synergize with morphine, we could synergize with codeine, but we wanted to know, we asked the question, okay, if you do set up this low-dose combination, so you've got it, a very low dose of morphine, very low dose of delta-9 THC, and you're administering these for a long period of time, will you develop tolerance to this low-dose combination? And the bottom line, our question was, will this yield tolerance? Because, again, we don't want to give somebody a low-dose combination if they're going to get tolerant, because they get tolerant to the morphine already. So what we found, as we've only gone out to 14 days, is that no, we do not see tolerance, and we've published these studies. But what was more fascinating was Diana Sichowitz said, can we prevent the development of tolerance? If we give a low dose of delta-9 THC along with the morphine at a high dose, can we prevent the development of tolerance to morphine? And we did. And can we prevent the development of physical dependence to morphine? And yes, we did. And we've published those studies as well in Journal of Pharmacology and Experimental Therapeutics. So those studies have been shown that you can prevent the development of tolerance and the development of physical dependence to morphine by injecting the delta-9 THC along with the morphine. Okay, then another interesting project came along. I had a nurse anesthetist working in the lab with me, and we asked the question, if you give this low dose of delta-9 THC, can you restore the efficacy of morphine? If you've got a patient that's punching their button all the time for the nurse and needs another dose of their Demerol or their morphine, etc., what if you went into that patient whose drug had worn off and you gave them Marinol instead? Would that work? So, of course, we did this in mice, preclinical studies. So here's a very high dose. This is of morphine over a time course, and the time course is from 30 minutes to 360 minutes. And morphine started wearing off. So what we did, this is the same curve, we added in an inactive dose of delta-9 THC, which would be equivalent to a 2.5 milligram Marinol tablet. And what we saw was that we completely restored the efficacy of morphine back to what it was when that person first took the morphine. And in fact, then we asked the question, which is not on here, how many times can you do this? How many bumps, as we like to call it, how many restorations can you go through? And what we found thus far is you can go through 6 hours of restorations. So that means that you can prolong the duration of the action of morphine by about 6 hours by doing this with the Marinol. The same thing was true with codeine. Codeine was active for 120 minutes, and when we used the low dose, inactive dose of delta-9 THC, again we found the interaction. And this is because it does not take very much of the opioid to be there for that synergy to happen. So as long as there's any opioid in the brain, as long as there's any codeine in the brain, you're going to have the synergy with delta-9 THC. So why does this happen? Since this hypothesis proved to be true, we went in and we've done some studies now looking at the receptors, and again, it comes back to the same thing, that when you have the THC on board, it's releasing endogenous opioids, and no matter how low the level of the opioid that's binding to the mu receptor, as long as there's something there, you will get a synergistic interaction. So all of this was done in acute pain models, but what are the most common kinds of pain to treat? These are the chronic pain models. And so what we did was, in the acute model, having shown all these various things that are listed here, we went on and we said there are chronic pain models, and one of the things that we'd like to develop is a patch. And I know you're going to have a talk on transdermal administration. But using the hairless guinea pig model, we asked whether we could synergize delta-9 THC with the opioid in a patch. And one of the reasons for this is to obviate some of the diversion of the fentanyl patch. When you have the Duragesic or fentanyl patch, it's a sustained release for up to 3 days, but the pain relief is obviously very good, but there is constipation and or respiratory depression which accompanies that fentanyl patch. And the lowest strength of the patch contains 18 times higher than the surgical anesthesia level. The reason for that is that you've got to have that huge driving force to get the fentanyl into the body. So even after 3 days, when these patches are thrown away, somebody can take the patch, burn it, and use it, and the abuse liability is there. So just jumping ahead then, since we had done the synergy, we used the hairless guinea pig model, and we developed a patch, and we found that, first of all, we checked out whether THC would enhance fentanyl, and this is a very low dose of fentanyl, a very low dose of THC, and at 10 minutes, this is the synergistic interaction, and at 20 minutes, here's the synergistic interaction with fentanyl. That's parenterally administered. We also looked at it subcutaneously, and then finally, we went to the transdermal patch. We developed the fentanyl so that it would pass through the skin with the tegaderm patch, and we found that our patch procedure was active, produced 100% analgesic effect at 2 hours and at 4 hours, and that we could significantly enhance. Here's the effect of the fentanyl, here's THC by itself, no effect, and if you put the two together in the patch, you get this huge synergistic interaction. So it will work by transdermal, it enhances it, and the potency ratio was 5.93. And these are the dose response curves of fentanyl alone and fentanyl with delta-9 THC in a 4-hour patch. And we're working on making the patch that last longer, obviously. So we can do it through the fentanyl. We can synergize with the fentanyl. The clinical implications for this are that the enhancement of the fentanyl could obviate some of the pharmacokinetic, pharmacodynamic differences in patients and reduce the fentanyl dose so that you would have less of the side effects, etc. Now, models of inflammatory pain. Would we see this interaction in inflammatory pain and in diabetic neuropathy? And those have been discussed here. These are clearly chronic models of pain that are critically important because of the millions of people that are suffering through, with these types of pain. We use the Freund's adjuvant arthritic model, which is a model of rheumatoid arthritis. And interestingly, what we found was that if you look at the ED50, the effective dose or the potency, if you will, of delta-9 THC, in non-arthritic animals and in arthritics, it's equal. And in fact, it's low in these paw pressure tests. In tests of pressure as pain, which is what an arthritic feels, is pressure on that joint is painful. Delta-9 THC is very active. The ED50 was 2.5 milligram per kilogram in the arthritics and the non-arthritics, which was interesting to us since they have very different physiologies. We looked at time course of action, and it was the same in the non-arthritic and the arthritic, indicating to us at least that the metabolism, et cetera, and clearance is probably the same in these animals. We looked at morphine, and morphine is equally active in the arthritic and non-arthritic animal. There are some studies that show it to be slightly more active in the arthritic. We didn't find that. However, if you look at the ED50 for morphine, it's 2.4. That's the same ED50 as delta-9 THC. So delta-9 THC is equally active to morphine in an arthritic animal in blocking pain. Now, synergy, yes, there is synergy. In this test system, morphine by itself, ED50 2.19, shifted to 0.5. That is a 4.4-fold shift. So this low-dose combination where we don't see the side effects, respiratory depression, that kind of thing, where we don't get tolerance, we don't get dependence, that kind of thing, we get full and full analgesic effect at a low-dose combination. This work suggests the potential for chronic analgesic treatment with a combination of the low dose as an alternative to opioids alone for chronic pain treatment. And I think that has been borne out by several of the old studies from the 1800s, that these two work together, and also by many of the anecdotal studies presented at the Institute of Medicine as well. Our recent studies have extended this to diabetic neuropathy, where we do see the same kind of synergistic interaction of morphine and delta-9 THC. Now, human studies. In 2003, a study came out by Neff, which was a very nice study. However, the doses that were used are extremely high. He used 20 milligram per kilogram, and I'm saying extremely high. The doctors here don't think that's very high. But when you see what you actually need, you will realize that this is a pretty high dose. 20 milligram per kilogram oral morphine, along with 20 milligram per kilogram Marinol, which is enough to make a person feel very dysphoric and very high. These are far beyond the doses that are necessary, and they did not see synergy in this study. And my take on this study is they had pushed the system so high that you would not see any more synergy. They were almost to the max with these studies. So another study in 2003 looked at delta-9 THC, a human study, with just 5 milligrams of Marinol in a surgical operative, post-operative pain study, and did not show good analgesic effect. This is consistent with the older studies showing that delta-9 by itself in acute pain is, or surgical pain, not a chronic pain test, is not as good an analgesic. However, there is a very good discussion by Croxford, and he talks about and this is taken from him, further understanding of the most appropriate route of delivery, which we've talked about today, pharmacokinetics of the agents, and the endocannabinoid system is all going to be critical to our understanding of how these treatments will work in a human. Now, unfortunately, our paper went in at the same time as Neff's paper to the same journal, and Neff got published first. Our paper is now being reevaluated by another journal, but what we used was a 2.5 milligram. He used 20. Neff used 20 milligrams of delta-9 THC. And we used morphine IV, weighing the patient, and we used 0.01 milligram per kilogram morphine, which doctors in here will recognize as a very low dose of morphine. And we got synergy with these two low doses in thermal pain tests in normal volunteers. And currently, we have a study that will be set up at Roosevelt up in New York City for chronic pain patients. So, I've talked a lot here. I've talked as fast as I could, trying to get us back on time. But the control of analgesia and hyperanagesia in chronic pain is really a puzzle to everybody. And clearly, the cannabinoids are one of the key players. They're the cornerstones. I didn't have time to go over how they're modulating in arthritis, the release of the endogenous opioids, but they clearly play a role in maintaining homeostasis, along with the opioid system. So these two are interconnected. Now, two systems that I didn't get to talk about are the NMDA system, which we have looked at with glutamate. There's been some talk about that today already, which we have just started doing a lot of studies on. And another very interesting system, which we have actually published abstract forms on, but we haven't actually gotten the papers out yet. And this is the muscarinic cholinergic system. The reason we're very interested in this is that chronic exposure to cholinesterase agents leads to chronic pain states such as are seen in Gulf War syndrome. And so we are very interested in the fact that the muscarinic cholinergic system appears to be one of the puzzles as well, playing a role with all of these other systems in the modulation of analgesia, hyperalgesia, and chronic pain, and may provide for alternatives to therapies for the treatment of these various disease states. So with that, I would like to thank everybody, thank NIDA for the funding that I have received for many, many years. And if you have questions, since I will not be here tomorrow, and I have this helmet on because I will not be here tomorrow for the question and answer period, please feel free to contact me with any questions directly. Thank you very much.